Hello and welcome to the Life Fit podcast. I'm your host, Jack O'Halloran, and today I am bringing to you a conversation I had with David McGettigan. David McGettigan is a P-DTR therapist. P-DTR is a non-invasive neurological therapy technique, and its main goal is to restore optimal reflexive activity of the nervous system to stimulus. Now, David has a background in applied physiology and health science, as well as sports rehabilitation, bones technique, and many, many more. He's a fascinating guy who with absolutely mad insights and is doing the good work out there. You can hit him up on his social media. He is the pain and movement specialist on Instagram, or find his website, davidmcgettiganclinic.com. We discuss things in this show, such as what is PDTR, the brief history of it, how does one, whether you're a therapist, get trained up in it and maybe do the work as well, how do the mechanisms of it work in dealing with the central nervous system. We then touch in on pain science and kind of debunk a lot of myths and misconceptions around how damage is always present when we have pain and things like that. And then how to best go forward, so how to implement different strategies and different mindsets so that we set ourselves up in the best way we can. So without further ado, here is David McGettigan. David, how are you?
Not too bad, Jack, and yourself?
I'm absolutely flying at your staying amongst the midst of the coronavirus, are you?
Yeah, just about. I'm using it as an opportunity to improve my golf game.
All right,
My
all right.
local golf club is still open at the minute.
Jeez, I wonder will that last?
I don't know. I hope so because I'm not back into the golf, but I'm hopeful.
Well, you'll be swinging mad in no time. Well, I suppose, David, well, one is welcome to the show, and two is you are a PDTR therapist.
Yep.
Now, for those out there who are going, what the hell is a PDTR therapist? Excuse me. Could you explain it for our audience, what it means?
Yeah. So PDTR is just It's a treatment technique. It's a neurological treatment technique that's based, I suppose, in assessing the reflexes and responses that you see in someone's nervous system. So, simple model would be that you get input in from all of the tissues in the body, all of the different ligaments, muscles, tendons, the skin, etc. We have all these different types to do with, movement, to do with joint position, to do with vibration, pressure, stretch, all these different types of inputs. And that then gets processed, and we have responses to those inputs and to that processing. So PDTR is kind of looking at that to see if there's any problems with that incoming input, and if that's leading to maybe more protective responses in somebody's body than they maybe should be having and stuff like that. So it's a treatment technique kind of based in um, neurological theory. Really, it's kind of the stuff you'll see in a neurological textbook, that maybe is just information that people learn and they don't really have a practical application for. PDTR is to my knowledge anyway, is the most kind of, or the best attempt so far to make that stuff practical.
Okay, okay. And how long is it kind of hanging around the place? Who started it all off?
Yeah, so the founder is a guy called Dr. Jose Palomar. He is a Mexican orthopedic surgeon. He has been developing this work, I suppose, for the last 20-25 years. He's been teaching it in its current format for about 8 to 10 years, I think, and then teaching kind of earlier iterations before that. Um, I first took the course in 2015. When I was moved to London. I was studying PDTR over there, and it just seems to be going from strength to strength all over the world, especially in the last kind of 5 to 6 years. I actually first heard of it through American people that I knew, American therapists that I know who had just started to take it about 2 years earlier than that. And they were recommending it as, very, very in depth and powerful work. So I kind of remember going on to the website, which was drpalomar.com back then, and there was very, very little information about what was actually happening during a treatment. There were a few videos of people miraculously being able to do, um, you know, very, very hard physical challenges after very, very minimal inputs, which was very strange for me to see. Um, and then I suppose by the time I got onto the course, I really didn't know what I was getting myself in for. It's probably the best thing I have ever done, to be fair. But it's definitely growing all around the world. We're in every continent in the world at the minute. And since I started in 2015, I've gone on and started to teach this work myself.
Awesome, awesome. I suppose just to hit on that teaching role, I mean, in terms of, because that will link in then again with kind of training and how people might look for themselves, whether they're
Mhm.
pre-existing therapists or not, but how to get into that kind of a thing. Is it kind of a year-round thing, or you kind of work at around clinic times, or how does it actually work in that sense?
Yeah, so the course in total is 32 days of content. So we break that up into three series. So a foundation series, which is 16 days altogether, and then an intermediate series, which is 8 days, and an advanced series, which is another 8 days. Um, the modules, it differs in different countries. I mean, the most common kind of presentation of it, if you want to call that, is maybe 4 weekends of 4 days for the foundation series. In some places, it will be 3 weekends of 5 days, so a day less. It's a little more challenging because there's a hell of a lot of content delivered. To put it this way, you could probably slow the pace down and expand it out, and make it a little bit less challenging to learn, and still, have you could probably do that over maybe 6 weekends instead of four, instead of five. There's a hell of a lot of content in there. But that said, it should be, hopefully, if I'm doing a good enough job, it should be easy to learn, applicable in clinic, after the weekend modules. And then there's obviously support groups and online forums and all that sort of stuff that help the students as well.
Awesome. And I suppose in terms of, people getting into it, do you need some form of pre-qualification? Do you need to be involved in, have a nursing degree or have a physio degree or something behind you, or is it kind of open to anyone once they can prove that they're going to stick with it long term and so on?
Yeah, well, I mean, the kind of, you would obviously, to start to use this with anybody, you'd need to have some sort of insurable qualification. So whether that would be, like you say, a nurse and physio, osteopath, chiropractor, even like the likes of personal trainers, um, massage therapists, we've taught bone therapists, we've taught lots and lots of different types of therapists. Basically, it's mainly based in that sort of world. Um, there have been one or two people in the past who have taken it without background, although I would probably say that that's quite a challenge. Um, there's been a few people who have kind of changed careers to want to do this stuff. A few clients who've asked and are pushing to get that opportunity. They're looking to get out of what they're doing, and move into to bodywork on P-DTR specifically. So it's not the easiest of courses if you've got no background. That is for sure. I would definitely recommend, if anybody is listening and wants to get into it, without having background, that they get something, you know, behind them first, whether it be a physiotherapy, an NMT, neuromuscular therapy, a massage, something like that gives you the hands-on qualification, that gives you the insurability, and then, you can start to work towards your PDTR work.
Yeah, because like I could imagine anything with the neurological system, you need a good bit of a foundation in that knowledge before you can just say, okay, I'm going off treating because this is the magic bullet. There's obviously a lot more to it, and the joy of a course beforehand is that may take a year or two and so on, and that's a lot of time where you can learn your mistakes and learn your interaction skills and so on.
Of course, yeah.
So it's probably, it's, whereas people can get caught in the trap, because I'm sure what we'll get into in a while is some of your cases and things, and some of it seems borderline miraculous in terms of the recovery. So people can easily get caught into the trap of saying, right, I'll do this short course and just go treat that. But it probably doesn't do either the treatment modality service or the population service because there's not the whole construct to hold it all together, you know?
Yeah, of course. Yeah, no, I completely agree with that. I mean, there are there are obviously loads of lovely case studies that I have. There's loads of lovely case studies that many practitioners have, and regardless of the technique, there's more than likely there's experience sitting behind that as well. I mean, I'm graduated from my degree 10 years this summer, and I've been working with people for 10 years. So it's there's a lot of experience there, and there's also then I suppose the thought processes that PDTR gives, the ability that it has as a system to help you to know where you want to work with somebody in their body to affect the target tissues or the target area, the target movements or whatever it is. So there's a lot more going on behind the scenes, or I suppose from the therapist side, there's a lot more going on that I'm working my way through with someone than just what you see in a testimonial or something like that.
Hmm. Yeah. And I suppose to bring my own background in, where I first kind of came across it was in college, maybe 4 or 5 years ago, and our lecturer had done some training in PDTR, and he was kind of just showing us a few little tricks, and I was wondering what was he doing because he was testing on arm strength and maybe tickling the person's nose or making a clicking finger down around the leg. And when you see this, it's like, what is this kind of snake magic? But the more you look into it, it's like, it begins to add up. And could you, I suppose, explain some of the mechanisms behind it? And I suppose I know the central nervous system is heavily involved here, but I suppose in what sense and then what components of the central nervous system are we trying to get in working order?
Yeah, of course. I mentioned earlier about that kind of input process response model that we kind of briefly touched on, and what we will see is that the to put it this way, if you have um, sensitivity in the input side of the nervous system, your brain does not have a filter per se that can look at that and say, "Look, that's my old sensitized ankle. I'm not going to." Um, process that information the same way as my other ankle, for example, that's not been previously injured. The brain takes the information in, processes it, and responds. Part of that interpretation that happens before we have response may lead towards pain, may lead towards a lot of protective activity. So what we end up seeing from the PDTR side is we're actually assessing reflexes. So we're assessing the myotatic, the stretch reflex. So can you produce a normal myotatic stretch reflex? So what would that be? We can use that through muscle testing. We can use that through movement, in many different ways. If you are able to produce a normal response, then we've got no problem. We don't have to do anything. If we have a protective response where we have maybe too much tissue tone generated, or another type of protective response where we have too little tissue tone generated, then what we will see is that the myotatic stretch reflexes are being affected by the input the nervous system is receiving. So what we want to do is figure out why, basically.
Yeah.
Um, so for example, when you mentioned the I think I know that the lecturer you're talking about, I'm pretty sure I do. When he was demonstrating, he was putting a small input in that was changing the myotatic stretch reflex on a temporary basis. Yeah.
Hmm. Yeah.
So what we will often see with people is that it's not temporary, that there can be some sensitized areas in the body that may not be actually painful themselves, but that are linked, causing the central nervous system to maybe experience increased threat. They're causing the central nervous system to have more protective activity as a response to it, and they're affecting how people move, and they're obviously affecting how people feel as well. So the idea with PDTR is if we can assess where these reflexes are, um, and give the correct input in the correct parts of the body, the input that's necessary to help the system to self-organize again, then we can normalize the stretch reflexes that are, that have a problem. And it's a very, very non-invasive treatment technique. It looks, I know you've kind of mentioned it looks quite strange. You might see somebody making sound somewhere. You might see somebody rubbing someone on this the side of the cheek, and on the skin. You might see them using a toothpick. You might see them using a tuning fork. to stimulate vibration. There are lots and lots of different types of inputs our nervous system has, and Dr. Palomar has taken his time to map out how we stimulate them to increase and decrease their inputs. And I suppose the whole PDTR system is designed to help you to know exactly where to work and what type of input to give to allow the system to do its magic. Part of why I ended up doing this is because when I suppose, left my degree, or finished my degree, sorry, 10 years ago, I came out. I didn't have the best of practical placements and experiences there, so I wasn't that confident in my ability to help people. And I suppose deep down, I always really wanted to make a difference for people. So I started studying different techniques and different approaches, started reading loads of books and stuff like that. And there was lots and lots of good information there. There was lots and lots of questions. And I suppose, I'm sure you'll know yourself, when you get something that's good, it leads to probably more questions than it does answers. So for me,
That's the rabbit hole.
yeah, absolutely. For me, I was, you know, let's say I would treat someone with knee pain. I would do the kind of assessment I was taught in university. I would massage, I would manipulate if needed, somewhere, maybe a joint above and below, as we were taught. I would give graded exposure, kind of rehabilitation exercises. And from what I was taught, that I was doing, I thought, a decent job. And sometimes people would come back to me and say, A1, I haven't had a problem. I don't even think I need to come back. Sometimes they come back and say, yeah, it was good for 2 or 3 days, and then it seems to have come back. Sometimes they'd say no change whatsoever, and sometimes they'd say worse. And the questions that were going on in my head were like, well, that's what I was taught to do. So what am I doing wrong? What is it? The type of treatment? Is it the forces I'm using? Is it the exercises I've picked? There was so many questions based around all that, and I suppose the new neuro treatment techniques I studied, they were all giving me different perspectives, different answers. And by the time we got to PDTR, I started to realize that what I'm doing when I work with someone, the idea behind it is to affect their central nervous system, to create safety within their central nervous system where they currently have threat. And for me, apart from the education side of things, which is another really, really brilliant way to do that, PDTR gives a really kind of nice roadmap or blueprint, if you want, when you've taken the course and stuff like that, that helps you to know exactly where to give the input to create that safety again, or at least to rule out that the input side of things is one of the sources of this of the lack of safety or the threat for the person.
And I suppose that's a common thing you see in clinic is people come to you and in a sense they want you to fix them, as if they have a problem in a muscle, whether it's back pain or calf pain, whatever it is, that somehow the problem is the muscle and that it's the muscle affecting the muscle. But we know that not to be true. I mean, it doesn't take much research to find out that it's the brain that controls it all. And
Yeah, of course.
what we begin to find, I suppose, especially as you say, if we start out and we're unconfident and we're trying to seek this gratification, it's not always going to come. And sometimes you're going to go home with your head up your arse, so to speak, and you're going to be upset, and then that moves on to your next patient and your next patient. When you have the process behind it of, okay, it's not good enough to know what, and it's probably not, most certainly not good enough to know how. It's really the why behind it all. And I suppose for me personally, it's about then, okay, how do you also empower the person who's coming here treating themselves like a car, who's going to the mechanic, who's going to get fixed because they can do nothing about it. And it's giving them back that sense of control, whether it's of what they can do going forward, but and
Hmm.
maybe even not that, because that may be difficult sometimes, but also maybe let them understand why it happened in the first place. What was the pattern that led to it? And generally, as time goes on, I suppose with that process, I've personally found that the results become far more consistent. You know, and I think that's a powerful thing. And as advice to any practitioner starting out, um, you're going to run into that wall. You're going to run into that confidence wall, and so on. We think all these techniques, whether they're dry needling or massage or this and that, that they're the answer, and they're passive therapies in a sense, and they can
Yeah.
provide an opportunity to negotiate with the nervous system. And that's
Hmm.
really where, for me, that's where the real value is that
Yep.
communicating with the self, because it's the self that got the person into the trouble in the first place. In one sense, we have to take responsibility for our injuries
Mm-hmm.
or for our life in whatever way we can. Um, but yeah, really bringing it back to that, and kind of what I like from what I've seen with PDTR is it's a very nervous system orientated thing. And once we're talking nervous system, we're kind of talking, okay, we can communicate with that. We can begin to
Yep.
develop some control. So I suppose if you would, you might walk me through, say, what your average session might look like, because people might have all ideas in their head of, will it hurt and will it, all of these kind of things. So maybe you might allay some fears and also answer some questions for people on that.
Yep. Well, first of all, does it hurt? It definitely doesn't. It's probably the most non-invasive treatment approach, one of the most non-invasive treatment approaches anyway that I have come across. There are very simple tests. There are very simple non-painful stimuli or stimulation of parts of your body that are, and we use reflexes. So the deep tendon reflex, if any of you are not sure what that is, if you Google patellar tendon reflex and you see a person get tapped on the knee with a tendon hammer or just with the person's hand and see their knee jerk, that's all it is. It seems very, very, I suppose, unrelated maybe to what you might be used to as someone who's experiencing treatment. Trust me, there is a logic behind it, and the actual magic is done by that deep tendon reflex, allowing your system to change protective reflex activity back to normal again. And for me, a kind of a normal treatment, you see, the kind of people I work with usually have been on that merry-go-round of maybe going to see different types of treatments. Like you mentioned earlier, Jack, they're looking for someone to fix them. Um, a lot of the time, or maybe they're just frustrated that nobody seems to be able to help them. So I would see people who've been around the block, who are frustrated, who are not really getting the results that they want. And I suppose the first treatment with me will always be to start with an education piece. So I want to first of all know exactly where that person is at before I start to kind of make a plan in my head at least, but where we have to get them to. Um, and for me, that also uh, that involves a lot of education. And if you're listening to this and you're not really sure or familiar about how education plays into a treatment session, um, I'll offer it to you this way. I would probably say that if we can unplug, or if we could unplug all of the learnings, the cultural learnings, the myths, the belief systems, the previous experiences that someone has had, the labels and diagnoses that they've been given, if we could unplug all of that stuff for a while, we would probably see that people experience a lot less symptoms. And the reason I say that is we're talking here kind of, I suppose, without naming it, about the biopsychosocial model. What we're looking at is the influence on how you're thinking, how your thought processes, how your previous experiences, etc., how all that influences symptoms. A lot of people I meet are told that their pain is all in their head. By multiple different types of professionals, and I completely disagree. It's always real. It's always real. Nobody can get inside your body and tell you that something isn't happening. Nobody has the ability to feel what you feel. Um, so what I see very, very often, especially when pain becomes a longer term thing, is that the person's not necessarily at a conscious level. They may have a lot of belief systems. They may have a lot of understandings about their body that might have even been handed to them, unfortunately, by maybe a healthcare professional or by what they've read in Dr. Google or read in the paper or whatever, that actually predispose them to experience more fear, more anxiety, more worry, more doubt are in their body. And ultimately, that will lead to being more likely to experience symptoms. So the first treatment for me is always a get to know the person, start to listen to them, start to understand what's been happening for them, what they experience on a daily basis. And of course, in the back of my head, I'm doing the kind of, okay, let me check this part of the body and that part of the body from a PDTR perspective. But I'm there to listen first. I'm there to um, see if we can start to pick up on any things that could be driving some of these symptoms for them from the psychosocial perspective. And then I will often start to just ask them the simple question: what is pain? How is it created? What's it
Mm.
for?
That in itself.
Barring,
Sorry, go ahead.
yeah, you're right. That in itself is a massive
Yeah.
topic, because barring, the first, well, most people will end up describing their pain again to me. They will start to tell me what it stops them doing. They'll start to tell me how it happens in terms of movement. So when I bend this way, when I move that way, when I'm reaching around in the car, etc., etc. And what I'm really kind of starting to pick up there is that you're telling me, you're describing things. The person's understanding of what pain is and what its function is very often is not really there. They haven't really thought about it that way, and that's important because, for example, when you start to dig into it, most people will start to associate pain with some sort of damage or injury or tissue irritation in their body, and that can, of course, be the case. Very often, there's none of that happening, especially whenever symptoms are longer term, especially when the symptoms haven't kind of been preceded by a tissue injury like a broken bone or a ligament injury or a muscle injury or something like that. So, when we start to see this pain equals damage, I start to educate around threat and all that sort of stuff, and we start seeing that that belief system that pain links to tissue damage makes all pain more threatening, because it's linked. It
Mm.
means for that person that they're ending up with some. I've got something damaged in my body now. I need to protect myself, or I need to rest. I need to not move, etc. And that can sometimes lead to a loop. I'm kind of away off my session here, or what my session. This is,
Self-fulfilling
I suppose, where
prophecy,
it's
doesn't
taking me.
it? Yeah.
Yeah, yeah. But no, when all pain is considered more threatening, your brain will respond with the most effective way that it has to change your behavior and get you to protect yourself, which is a pain experience.
And that's the thing. I mean, our brains really. I mean, what I'm noticing, even from my own, I suppose, as I say, the rabbit hole with pain science, with the likes of P-DTR and different things, is it is all, and not in the Irish in the stigma, but it is all in the head. And more what I mean, it all comes from the head, or at least it's all interpreted and then dished out from the head. And to think of some processes we have in the head is like our brain is really good at shortcutting. And that was probably whether it's an evolutionary technique, so we've less mortality rates with childbirth and things like that. But our brain, it's learning in patterns, and it begins to metaphorize and all this. And you take this problem of how we perceive pain, and for those who don't know, our model around pain, and most of Western society today is like it's Descartesian. It's from Treatise of Man in 1664, and it was wrong then, it's wrong now, and we all know ourselves that like pain. One big issue I see is person comes in and they say, "Oh, I have pain," but I mean that's a if we learn in patterns and we're putting that overarching word to something like a paper cut or something like childbirth, it's not fair, and we're going to create the same protective responses because the brain will just say, okay, here's the pattern for that, here's the pattern for that. And these therapies, the likes of cognitive function stuff, the P-DTR definitely seems to add in with that, and it's part of the new family going forward and how we're dealing with, I suppose, these misconceptions. For me, it's this idea of when I see somebody coming in the door, I see them with their toolbox, and it's how many tools have they got to deal with whatever it is they're feeling, whether it's pains, aches, this or the other thing, and then can we then make sure that when they leave, they have more tools, as opposed to the old model, which was, oh, geez, it's damage and it must be this and there must be a problem outside of the human, and then we can blanket treat everyone. But I mean, sometimes, maybe the person's shoulder is sore because they have very young kids at home, they have a lot of bills, and they are a plasterer for a living. And, the risk of the shoulder going down means an awful lot more than just pain itself. And that's a huge thing. And for me, I had to learn that the hard way. I tore my calf maybe 2-3 years ago, 2.5 years ago thereabouts, and it was grade 3 tear. I couldn't walk for maybe 8 weeks, and it was fairly sore, but the pain didn't really bother me. What bothered me most about the whole thing was not being able to bring a glass of water to bed, or not being able to play soccer, or not being able to be dancing when I'm out, and all of these things. And it's how the experience as we experience it, which comes back to choice, and we can choose how we experience anything, but how we experience that and how it affects our existence in the world in terms of a self-effective kind of being, an agent, that we're adaptive and so on. And that's the crippling thing that you see a lot in the industry. That in effect people are coming out of the places maybe with less pain, which is usually temporary in those cases, but with less sense of adaptability, less sense of, oh, I know where to go, I know what to do for myself. And I suppose that's it's a sad thing to see, and it's a rabbit hole that people hopefully don't go down. But I mean, we have ample evidence, ample techniques such as the PDTR. Exercise probably being one of the best treatments out there because it allows for, once done in a controlled and kind of, if we can scale the pain, it it helps develop safe memory so that the brain can, when it's dealing with that input coming from wherever it's coming from the body, it'll say, oh, wait, I have this memory of being tough and strong and all of this from all of those hours of being tough and strong. So it won't perceive those as threats, and you get the desired output as opposed to the overly protective one. But it's a fascinating subject in and of itself, and it's kind of, each thing has its rabbit hole. But probably, for me anyway, one of the biggest challenges with it will be, and especially as a society, is if a medicine in effect has to be all about the person, like it's a really subjective medicine, is how can we ever roll it out, on a national level when, we have a situation whereby there are certain practitioners in hospitals and those type of settings that might only have 5 minutes with a patient, might only have 10 minutes, 15, whatever it is, and you can't even get to know them, and you've seen this yourself. Sometimes the act of a conversation, and maybe the person might vent about work or a partner or something, and that venting alone can de-stress, and that even just the venting side of it can be enough to, deactivate some responses within the body that can give you an opportunity then to rebuild stress, to redevelop a better memory of what's going on for the person. You kind of mentioned earlier on about the the whole treatment, the PDTR, is non-invasive, and the magic is in the little things, is kind of what you said. So, and that for me is so apparent. I mean, I've seen mad recoveries in people just from giving them a diagnosis. Something like even just telling a person they're safe, and all of a sudden they move better. Weird things like this. So the power of the brain is holding over us in that sense, and it's, for me anyway, it's not the prefrontal cortex analytical brain where the ego lies, where your name and your age and your identity. It's that supercomputer animalistic brain underneath, where the brainstem and all those old reptilian sides. And especially within our own Irish culture, there is a huge stigma around the phrase "it's all in your head," But I suppose now we probably need to recoin that. If people in other countries heard it, they mightn't be as insulted when they hear it, but it's certainly an issue here. So I suppose, how would you go about kind of breaching that for people? So obviously you develop a relationship, which is trust, and so then they're probably willing to listen. They've probably trusted you a lot before they got there because they've seen your social media and they've seen your website and so on. Have you any kind of go-to strategies with people, or any kind of go-to things that you've learned that when dealing with people that you find tends to not to be overly blanket treatment here now, but in some sense?
Yeah, I suppose like for me, that's why I start with the education piece, because I would kind of see it that if a person has a lot of those previous learnings, previous associations, belief systems, etc., that are predisposing them probably to more symptoms than they should be having, a lot of times I'll take to my little whiteboard in my clinic room and I'll draw it up for them so they can visually see it instead of me just talking about it. And I'll explain that we want to work with your nervous system, not against it. We want to have a conversation with it, and the best way to do that is to, well, I suppose, start to help you to understand, I think, what may be influencing this picture. Because usually by the time I see people, they're quite frustrated, maybe they've completely lost hope that they have, that they're ever going to get over this, or they're ever going to get their life back, whatever that may mean for them. And typically there's a lot of aha and light bulb moments that, for example, if someone's been doing their rehab exercises and they're still experiencing symptoms, and they've not been aware that behind or beneath the surface that all of these negative associations about their knee or about their back are present within their nervous system and have been handed down to them over a period of time, and that are exacerbating the symptoms probably, or at least influencing them, then if they're not aware of that, then how can they ever make any progress with it? It's not until we start to bring that up to awareness again that a person has that, okay, maybe this makes sense as to why I've been experiencing pain, because maybe I want to get my knee better, maybe I want to make my back feel better. But all of the stuff that I've learned about lifting the right way, about moving the right way, about exercise, about my back, about my degenerative disc, about all of these things that people get told about their body, maybe that's always tipping things in favor of having to protect myself rather than me overcoming that. And that would definitely be a start point for me. And what I want to work with the people on an ongoing basis is, again, I would use the P-DTR work to do my assessment of the functional side of their body to see if they have any reason why they may not be able to produce force in a certain muscle group, or a certain, maybe not be able to access a certain movement. And what we want to see then is over time what their feedback is. So I'll be checking and rechecking movement and previous indicators that usually would cause symptoms for a person. I'll be checking those maybe 10, 15 times a treatment. And by the way, my treatments are an hour and a half long, so they're a little longer than some. Um, and then I'll be looking for people to get feedback from me over time. And for me, what I want to do with people, I suppose, is to find the biggest drivers of their stressors, of the increased threat in their system, help them to understand how that affects them, then help them to create change around that, whether that's me with some treatment, whether that's movement stuff, whether that's giving them a strategy as something as simple as, right, let's get you to focus on your sleep. You're sleeping 4 hours a night. And we know, I explain a little bit of the kind of stuff about losing the ability to block the incoming nociceptive input and all that sort of stuff, when we don't sleep well. And this is just going to have a role to play here. And maybe we can just get you to create better sleep hygiene and better sleep habits and start to, attack it from that end. And I suppose when we can start to create safety in a person's nervous system, have a communication with the person first, um, have an effect with the person's nervous system, and help them to regain hope, regain confidence, then we're on the road. And I actually think if we can start to create change around a previously threatening context, even just one, it starts to show a person that there's possibility for change to happen, and that's powerful in itself. And then my process, I suppose, is about doing everything I can to figure out with the person what is increasing the level of threat for them. And when we figure out what that is and change that around, whatever it might be, then we offer their nervous system a chance to go back to all of the previously threatening contexts that it may have associated as been related to your back pain or related to your knee pain or whatever it is, and it has a chance to reappraise and to kind of reevaluate and say, is this still the same as it was? And if it's not, you should see that symptoms are decreasing, they're less frequent, they're less intense. And in a way, when you start looking at it through this neurological lens, um, I think people's nervous systems, especially the ones that I've worked with who are kind of overcoming long-term symptoms, who are getting back to work from not being able to work and stuff like that, I actually think their system learns its way out of pain over time. That might be a strange way to look at it, but that's what I think it is. I think it's the amazing plasticity that we have in our nervous system. Things can change.
To touch on that, because I suppose I notice a lot of resistance at times with it, is that there's this belief that, that, oh, I'm old and it's fine for you to say this as you're young and different things. But
Hmm.
from what my understanding, I mean, the processes of the body, whether that's genetic up or down regulation, whether it's, absolutely any adaptive process within the body, it never stops whether you're 2 or 92. Now, the rate of
Hmm.
which we might regenerate quicker as a 2-year-old, but even if we're 60 or 80 or different things, like the process itself doesn't stop. And I think when we
Yeah,
have this focus, when our focus is on the external, so the problem is the muscle and that's damaged and so on, we can
yeah,
often kind of lose sight of look, whatever we put ourselves through, we adapt towards,
Yep,
or we, we sink or swim in a sense. But it's like if you started playing guitar, you'll get calluses in your fingers. If you want to look like a bodybuilder, you got to bodybuild. If so it's
of
getting
course,
people
yeah.
into this mind frame as well, and that's regardless of age. Now, for me, that's a liberating thought, but again,
Yep.
kind of stemming in with in a sense half of the industry that the likes of us may be battling, that old Descartesian model of nearly looking at the body like a hydraulic mechanic system, that something equals this, and then you can blanket that out across everyone. But I mean,
Hmm.
it doesn't take a genius to realize you could get two people in a room and say boo, one of them might jump and one of them might laugh,
Hmm. Of
so
course.
the stimulus itself is never really the issue. It's what happens to us and how we as an individual get over it. And the response from when you can take somebody who maybe hasn't been able to see that for themselves, and then all the consequences from that, such as uncertainty and panic and fear and negative expectation, negative belief, and you're able to create that cognitive dissonance to say, well, actually, here's a direction for you, hopefully give them some meaning around it, change their focus from that negative to a positive, and then give them even a simple strategy. It could be a low hanging fruit, it could be a simple change, like while you're watching TV, sit on the floor instead of a couch. That could make all the difference to your hip health. And these are things we can actively get in on ourselves. And it's really about bringing that power back. And I suppose we spoke on the health industry and the way that's kind of gone in the sense of an overloaded system. And we don't have time to treat anyone the way people should be treated. But maybe we shouldn't actually need to be treating people half as much. That could be half the thing. If most of us were empowered in terms of how to accumulate all of the habits. So to know simply, if I don't know, if I want strong legs, then I better do some strong stuff with my legs. If I want to look like a marathon runner, I got to run marathons.
Yeah, of course, yeah. I think the problem we face with that is that the the kind of culture or the learnings, the kind of the general consensus among non-clinicians, to put it that way, or the general population, is usually based in, or has been based by the guidelines of the medical profession and stuff like that. But that stuff is usually about 20 to 30 years out of date. I think I shared something on my social media recently. It's from a study that I read that they were they kind of were saying. I think this was even 4 or 5 years ago that on average it takes 16 to 17 years for research to reach the clinicians when it's been the majority of clinicians whenever it's been released. And obviously, if that's taken 16, 17 years to get to a therapist of some description, then for that to get to the general public to be the prevailing view, it's probably going to take 30 years, 40 years, maybe more. So, in order to get us to that not over treating scenario and providing just the amount of treatment that a person actually requires, we probably do need to start massively educating in ways, or starting to hopefully create change with that. I think it is happening. I think it's just, I suppose it's going to be individual as to where what a person has heard from like their previous therapist, or what research they've done themselves and stuff like that. There's a lot of fantastic educators out there doing great work with that. Um, but I think if we don't improve that, or if we don't get that kind of spreading through the therapy community, through the personal training, the exercise community, the medical community especially, um, then it's kind of pushing against the tide. There's I get a little frustrated sometimes because I hear consistent messages coming from very, very well thought of healthcare professionals and doctors, surgeons, stuff like that, who are dealing with people who they're not even taking real care about what they're saying to people. There's a lovely quote, for example. I think it's by a lady called Pearl Strachan Ward, which is take care take care with your words, for they carry more power than atom bombs. Even just as simple as being aware of how your language affects someone is massive. Never mind the advice you're actually given. It's that for me is a little frustration, because there's a lot more that can be done that way with people. Um, and that's going to be part of what needs to shift in order to kind of break away from this not really using effective treatments over the longer term and stuff like that. So I think this, if we want to really empower people, we have to start empowering our clinicians to think differently.
And it is, I mean, in those little things, and like the words, it's absolutely huge. Like, to give an example, in the clinic setting, I suppose if I had a person with a sore shoulder, for example, and I asked them to move their hand, or I got them into a particular motion, say flexion of the shoulder, and at a certain degree in that we found that, okay, so say at 90 degrees the shoulder gets sore. But instead of saying, oh, so you can only get to 90 degrees, if you say, oh, great, you can get to 90 degrees, there's a different focus then, and I've found myself just through, and it's only case by case, it's not research driven or anything like that, but I found there is a profound impact on that. And quite often I get phone calls from a prospective client. They ring me up and I say, look, what's going on? And a lot of time I'm hearing, all this scaremongered language of stuff like, oh, I have bulging discs and this and that and blah blah blah. And it's like, on the one hand, on one hand in my head, I know things like, was it 50% of the Olympic athletes or 51% of the Olympic athletes in 2016 had spine disease of some description, yet they were Olympic athletes.
Yeah,
And again, it goes back to that whole obsession around the damage. And it's like, for me, like our brain, if the way I like to think about it is, its priority is keep the heart beating and keep the two eyes facing forward parallel. Once it can do that, it'll do it by hook or by crook. It'll take shortcuts, it'll make mistakes, and so on. It tends to learn in patterns and metaphors as opposed to actual specific truths. We have to be very careful what we kind of bury, either literally in our head as a belief system or metaphorically. And the research is there to back it up. I mean, we see cool research around the likes of, learned behavior or learned pain expression based off of what a parent experienced, or a friend, or things like that.
yep,
And it's trying to unravel that for people, and it's getting people to
yep,
look solution orientated and say, right, it's not even about this pain that I'm suffering with today and for the last month. It's about me. My name is John, Jimmy, or Mary, or whatever it is. It's about that, and for the rest of my time. And kind of one way I think is like, if you had a stone in your shoe, but somebody was running after you with a gun, you wouldn't be long forgetting about the stone in the shoe.
of course.
And it's this whole idea. It's not about that stone in the shoe, or it's not about that, the tear in the muscle, or the whatever the heck it can be. It's about, are you still adaptive? Are you still able to go out there into the world and kick some ass or not? And a lot of the time, people are coming,
Yeah,
and generally, the more chronic a case may present, it appears to be that they don't feel that way, that they feel disempowered, that they feel self devaluated, and so on, which, metaphorically speaking, would give us a sense of weakness, which will probably manifest physiologically then, I believe. Um, so yeah, there's a huge, I think, responsibility on the likes of us is to try and help break that down in our everyday reaction. And we'll meet resistance. We'll meet people who say, oh, look, I just have a bulging disc or whatever. I just want you to massage me, or I just want you to do this. I just want you to do that.
yeah,
And we'll have to deal with that resistance. But eventually, I think the truth will always come out, and then that will, hopefully, if things
yeah,
like the Bible or different things like that are to be believed, hopefully it'll liberate us too. Um, so yeah, I suppose, to move on a bit from that, and maybe you could walk us through, or talk us through, maybe one or two, or 10 if you'd like, a couple of interesting cases you kind of came across, maybe on what it entailed, from what, obviously, maybe we might mention names and things like that for our
of course. Yeah,
GDPR in this
yeah.
P-DTR podcast. Um, so you might,
You'd be rapping now.
I know, Genie, I'm like a Biggie Smalls or something. Um, so I suppose, just talk us through maybe what presented, and then
Yep,
in terms of what we talked about already, so that the likes of the personal story, how things like that maybe affected that case, and what were
yep,
the kind of, you know, the cool things that kind of came up in it. So maybe you might have a few ideas of some already. You can fire ahead.
yeah. Um, I had one last week. Just to start there. I had a lady who has had a knee replacement, um, which didn't go so well. She kept swelling, kept blowing up. It was affecting her work. She couldn't get back and walk even without pain. She then had a revision surgery, and again was still having red hot, stinging, angry knee, as she explained it to me. And going through the process I was explaining earlier about, we did a bit of education around it, we did a bit of explanation around these things. And from the PDTR perspective, when I assessed her, she was unable to produce force through her quadriceps. I could literally push them over with fingertips. And what we did was we interacted with the scar from the first surgery, or from the surgeries, the knee surgeries, and immediately the quadriceps were able to produce more force. And then when we actually treated it perfectly, she was able to put force through her knee in a very, very different way. So she was able to actually start walking again pretty quickly in the treatment session. And she left me a little message to say, I can't believe the difference. I'm back walking pretty much pain-free. I'm getting stronger every day. And, from my perspective, all we did is interrupt those very, very, I suppose that we can assume that they're threatening messages that are coming from the scar tissue in her knee. So make them normal again so that she's getting normal input from those tissues rather than sensitivity. And that was lovely. She's already back motoring. One of the things that, just to briefly jump back to what you just mentioned in the previous section, was that I always ask people, what's the goal here? And usually they'll start to say, I want to be pain free, I want to just get my life back. And I'll say, but what's that thing that maybe you're not allowing yourself to even think about? So let's say for that lady it was, I want to get pain free, I want my knee to be okay, I want to be able to work. And deep down past that, she was, I want to get back to play tennis. So I was like, right, that's the goal. Because when we set that as the goal, you have to have overcome what you're experiencing now to move forward. So stuff like that. That was a lovely treatment, and I'm looking forward to, well, as long as coronavirus effects off sometime in the next couple of months, I want to get back to treating and helping her to progress. I've had loads of lovely treatment experiences. I work because of the teaching. I teach all over Europe. I've worked all over Europe. I was in Iceland last year. I was working with a lady who has multi-chemical sensitivity. So there was mold in her office, and she became very unwell, was hospitalized, etc., and overcame the kind of acute stage of all of that. But since that, she has been unable to go into certain buildings because of the sensitivity that she has to chemicals. She's unable to, use perfumes. She's unable to, be near cleaning products, all that sort of stuff. And the PDTR assessment showed up that she had quite a few sensitivities around her head and neck of the nociceptive side of the nervous system, which is the threat side of the nervous system, that when we treated those, she was not able to reproduce the same sensitivity. And I even left the clinic because it was my last client, and we went to the buildings that she previously had problems with and reassessed her in every one of them. And she has no reoccurrence of symptoms. She was having horrible adrenaline rushes, like very autonomic type symptoms, very kind of sympathetic nervous system, fight or flight type symptoms. She had diarrhea and different bits and pieces, and all of that stopped due to the treatment, which was lovely. Another one would be actually quite a few nice stories from Iceland. I had worked with a lady who she had every type of scan you can have, every brain scan you can have. When she moved her eyes to the right, she would start to faint. When she side bends her neck in a certain angle, she starts to faint, and there is no known neurological reason. There's no problem with her brain from any of the testing that they can do. And that took me a long time to start to figure it out. When we worked it out, for that lady, there were quite a few things happening, and one of the bigger drivers was a very, very traumatic emotional experience. And one of the techniques, one part of PDTR is that we teach how to assess some of the neurological components of a traumatic experience. So if we have, for example, if you become angry for no reason, with the PDTR protocol, we can assess what part of your previous experience is triggering those responses for you on an ongoing basis, and see if we can start to desensitize that. And by doing that, we were able to stop that happening, and her energy started to return. She was able to start getting out walking, starting to exercise, to do yoga, etc., etc. There's loads and loads of experiences like that I've had, helping people with unexplained tremors where there's nothing on an EMG, helping lots and lots of people to move differently, to improve their strength. There's loads of different experiences, and like everybody, there are people that I haven't been able to help as well, where it's been really really difficult or impossible to figure out what's driving these symptoms for them. So, um, I have had loads and loads of really really amazing treatment experiences, and it's, I suppose, you maybe take it a little bit for granted at times whenever you see some wacky things happen. There was a recent one over in Denmark with a lady who has a big tremor in her neck. And what we worked out was that just by stretching her right leg forwards, we were able to cancel the whole tremor out or negate the tremor. And it ended up being a problem with how she processes visual and auditory information, which is involving moving her eyes to a certain part of her body, making sound in a certain around a certain joint, and there's the spinal tactile pathway that we would teach in PDTR. But without going into that here, by reintegrating that again with her system, she was not having any of the responses that she was experiencing for a long, long time.
And how could something, let's say, like something there in her leg, whether it is an auditory thing or something like that, how could that
Mm-hmm.
affect? Could you break down for us how that could affect something like up in the neck? And
Yeah,
would it be same side always, or might it be the opposite sides
no,
and so on?
no. This is part of the reason I love PDTR, is because every single presentation is completely unique. Everybody's nervous system is completely unique. For that lady, I was teaching, and I was able to observe when she was sitting down the back of the room for the last maybe 10 minutes of teaching. Um, that she was sitting with a very very strange seated posture. She was really really rotated, with her right leg rotated way around to the left, which was, it looked like she was, you imagine like a towel being wrung. It was kind of that level of rotation. I was going, that's quite strange. Um, Long story short, when we assessed her, we started to assess PDTR style. We started to assess her stretch reflexes. She wasn't able to produce force anywhere, without stretching that leg forwards. And when we, the PDTR kind of process will teach you a roadmap. So if I, for example, found a problem around your pelvis, if that was not the main issue, that was a compensation itself, it will teach you how to find out where the main issue is, what type of stimulus you're looking for, what type of area of the body, etc. And for her, it worked out that her the, the visual input. So there's a pathway called the spinotactile pathway, which is, it has a function to bring your eyes and your head towards the source of a stimulus. So for her, it was around her ankle, if I'm remembering correctly. It's on a video, I can rewatch it, I can't do it now. And what that meant was that in order to move her eyes towards the ankle, if you think about it this way, you have to look down. So we start to facilitate and inhibit or change the tone in certain muscle groups in the eye itself, then in the neck, and potentially in the lumbar spine, to start to move you towards being able to see your ankle. And when we started to assess her, if I asked her to move her eyes away from the ankle 180 degrees, she was as strong as a rock. This lady had worked in the military, was very, very fit before this strange response started to happen. When we asked her to move towards it, she was unable to produce any force basically anywhere in her body. And we worked out through the process of working with PDTR that that was compensated for by auditory input. So the movement of the eyes towards the ankle and the auditory sound were actually inputs to her nervous system that were sensitized. And they were specific to certain directions. This might not be making very much sense for people out there, but it's very difficult to describe over this medium. But long story short, she was having multiple muscle groups in the body, a lot of muscle groups in the body that were decreasing their muscle tone, that were less able to produce force than they should have been because of the input she was receiving from these areas. And when we were able to kind of reintegrate that again, we stopped all those responses from happening.
Yeah, and she was. I suppose in one sense, was she receiving information where, like, she shouldn't have been? And then was there the areas that maybe she should have been receiving information? Is it a case that it doesn't happen there then? Or maybe I'm asking a silly question.
It's not necessarily that. It's you could be taking, if you should be taking, or you are taking information in from every part of your body all day long, every day. And what seemed to be happening in her case was that some of the inputs from certain places in her body were highly sensitized. So even though she was getting, let's say, normal auditory input from her left knee, she was getting abnormal auditory input from her right knee, which might sound quite strange um, when you haven't seen it or experienced that in your own system. And just the PDTR process is to find these things. It's to help you to understand that, the like we've talked about earlier, that the muscular system, for example, is just doing what it's told because of the higher centers, because of the spinal reflexes, because of the higher centers. So if in essence, if the muscle is the slave that's been told to do what to do, told what to do, sorry, by the higher centers, we have to figure out why the higher centers are telling them to do that.
And is it objective in that sense, as in because the nervous system, from my understanding, it tends to tell the muscles and so on to do a lot of stuff, but it's just not always the best advice, seemingly.
Yeah, yeah, and I mean that's, again, for me, that, keep it really simple. That stuff, that response in the system is based on your processing, your unique set of lenses, which are built with your beliefs and all that stuff and all the previous experiences you've had. And it's also based on the input you're receiving from your internal and external environment. So for me, instead of trying to reverse engineer the lack of muscle strength, for example, so if you have a lack of muscle strength and you're trying to build up strength with exercise, rather than trying to build up strength, let's figure out why it's not strong in the first place. Why your system is deeming this to be threatening enough to not produce the same force that it was. Figure that bit out, sort that, and then we can revisit the actual strength exercises. And when I do that with people, many times they'll turn around to me and say, those lunges, I breezed through them. I didn't I didn't ever, or I haven't ever had such an easy session. I think I can actually progress from that now, whereas I was really struggling to feel anything in those tissues, to gain any progress with what I was doing, etc. So I think the kind of analogy would be that if, let's say, yourself and myself are walking down the street somewhere and Vodafone have a new advertising campaign, and they've got a big billboard in the middle of the town that we're walking down, and they've got a massive flaw with their advertising campaign. If you and I run into the Vodafone headquarters across the road and tell the first person we see to change your advertising slogan because it's going to lose you a lot of money or something like that, if we tell the cleaning staff, do they have the power to change anything? They can communicate up the chain for sure, but they don't have the power to enact any change themselves. We need to talk to the marketing director or the CEO or somebody like that. And in the nervous system, it's very similar. Your muscles have the ability to do this communication up the chain, and they respond. They're told what to do, um, but it's not them that are responsible.
Hmm.
Higher centers.
In a general sense, kind of what advice would you give to your average Joe, to the layman, from a PDTR perspective? Obviously, the advice would be, if you have an ongoing issue, go and see David McGettigan, PDTR specialist. But I mean, in terms of what we can do for ourselves, just as humans, and in the sense of maybe reducing the chances of these complexes within our nervous system.
Yeah, I think for me, it's what I would say to people on that one is educate yourself around your own body first of all. So any unnecessary fear that you are currently experiencing, if we can start to tackle that, fear sensitizes everything. So we want to tackle that first. And then the usuals, the lifestyle stuff, start to get more sleep, start to even just go out for a walk, get into nature, start to maybe take a little bit more of an active role in the stressors that you experience on a daily basis, if that's possible for you. Um, Basically to create some more resiliency in your own body. Um, And if we can start to create that, then you're going to be less likely to be affected by any of that stuff. So it's all the same, or the usual lifestyle advice that people will maybe hear or maybe not act on as readily because they don't really know why it's relevant for them. I believe that, I mean, I give it to you this way: if you're coming to see a therapist and you have more problems than you have fuel in the tank to manage, then no therapist on the planet's going to be able to help you unless they can take the problems away completely, which probably isn't 100% likely in a lot of cases. Um, a lot of times people need to fill the tank up a little bit more and help, yeah, give themselves a fighting chance, you know?
Absolutely. And I suppose it links back again to what we were talking about earlier on, and it's that I say fear is a big thing, and like when we have pain, if we have an injury, if we have whatever we have for a long time, like that becomes its own complex, and that becomes its own ghost, and all of that kind of thing. And I suppose the way I always think about it is, if you see a ghost, walk straight through it. This the old advice of avoid at all cost. Rest or take rest is fair to an extent when rest is what's needed, but also it's we don't want to avoid the scary stimulus. We want to find the point at which we can tolerate and build from there.
Hmm.
And it's getting people into that shift that then we can take what we find difficult, take what scares us, takes what all of those adjectives, take that and actually willingly take it on. As in like in Pinocchio, it's like go into the belly of the whale to rescue your father. It's that whole idea.
Yeah, yeah.
And in terms of the health, I think that's really where people, begin to get profound experience.
I think when you mention that, Jack, I think part of the reason that that doesn't happen a lot is because of that lack of understanding that pain can be from another source than tissue damage. So people are not really willing to take the bull by the horns, as it were, and start to challenge their body in any way or start to try to build some capacity or some resiliency if they're worried that they're going to cause more damage to happen in the first place. And, probably in terms of the people I would see, especially with the long term pain sort of population, I would probably say that 95% of them have absolutely no active tissue injury at the time that I start to see them. Um, I would even say it's that high, and they have scans to prove it usually as well. Um, so if there's anyone listening who is not a therapist who is experiencing pain, or even who is a therapist who's experiencing pain, don't be afraid to start to move your body. Your body is incredibly robust, incredibly resilient, and will respond positively to the efforts that you put in if you can start to shift past this. I'm creating more problems for myself because of tissue damage. The best efforts that you put in, if they are kind of framed within an understanding or a belief system that increases the experience of threat, it's going to create more pain experiences, which can become its own self-fulfilling prophecy that you're actually doing more damage, and that's why you get more pain. Very often it's actually based in that understanding. And if we can start to shift that along, then you can start to get back at, moving more, get back walking, exercising, get back to the gym, whatever it might be.
And it's like there's maybe it's the 2020 society. We're in this obsession with results and
Mm-hmm.
obsession with the end goal and the destination and all. But like everyone knows it's really about the journey. It's about what you get in between. And like we have ample evidence out there of people with loads of different disabilities, yet they still kick ass, so to speak, and like they still go out and they make of it what they can. And really, for me, that's what it's about, And if we can maintain that sense of, look, I know my toenail is falling off me, but I can still jump up here and catch the ball and put it in the back of the net.
Of course.
Um, and it's that whole thing, And unfortunately, people have to move beyond, again, as we mentioned before, this blanket labeling of pain.
Yeah.
Something I find very useful is, again, quantify that pain. If you can get somewhere between a 3 and a 5, maybe even into 6, so that tolerable level of the scary stimulus, and then even something like a deep breath, or a couple of them, or things like peripheral vision, different things like that to help just bring the focus back to the internal while the external chaos is going on. And what you'd notice, I mean, for people at home, try this out. Try a hamstring stretch, bring it up to that 3 or 4 out of 10, and take 3 or 4 deep breaths all the way in, letting that exhale go. and then reevaluate. It'll probably be a 3 or a 4, or sorry, it'll probably be a 3 or a 2 or a 1. It just gives us that
Yeah.
insight into how much we can actually do for ourselves. And we might sound as if like we're trying to put ourselves out of business, that everyone can do this for themselves, but wouldn't that be beautiful?
That's the idea.
Yeah, that'd be the most beautiful thing ever, because there's loads of other problems to be solving in the world. Um,
Hmm.
and when it comes to pain, as you said, nobody experiences it but ourselves, and in that sense, it's always real. Even though, yeah, it's in our heads, but it's in we're experiencing it, and there's nothing more real than us experiencing something.
Yeah,
We give the light to what we observe and all that.
of course. I mean, technically, it is in your head. I mean, the clients sometimes look at me when I turn around and say to them, "You've got a sore knee." If anybody on the planet surgically opens your knee right now, not one person on the planet can show me or point to me, there's the pain. Pain is an experience, not a thing, which is, people look at me quite strangely when I say that, and then I start to help them to understand that if it's an experience, it's influenced by many, many things, many, many inputs, many, many sources, and we can start to work on all of this stuff. So it's definitely how would you say, it's definitely an area where words don't do it justice. Words become a black hole at times when we start to try to explain or experience or help to maybe understand someone's experience, and at some point, words will fail us. And I think I
Mm.
come up against that with people very, very often. Um, it doesn't mean pain is any less real.
Yeah, and that's. I suppose, look, what we'll leave it there for today. We had a great conversation, an hour and 10 minutes in
Hmm.
total.
Hmm.
So David, I suppose, where can people find out more about yourself? And can they get in touch or book in with you and so on?
Yeah. So my website is www.davidmcgettiganclinic.com. That's David McGettigan clinic.com. I'm actually in the process of building another website for the P-DTR work, which will be pdtr.ie. It's about three quarters finished at the minute. It's on my to-do list now because of the coronavirus. Um, so I have social media channels. My Instagram handle is at Pain and Movement Specialist, all one word. Um, and yeah, I'm pretty sure if you kind of Googled any of that stuff, you'll come across me somewhere.
And we'll put all of these in the episode footnotes as well. And is there any kind of, I know you mentioned your new website. Have you any other projects on the go, like courses or different things coming up?
Yeah, well, I'm also attempting to build an online course, which is going to be slightly different than how I would treat in person. But build an online course to maybe help those who maybe can't travel to clinics or who can't maybe afford to get to a clinic and something like that. To give them at least the education pieces, the self-assessment through movement, the kind of rehabilitation protocols, the graded exposures, all of that stuff. I'm building that at the minute, and I'm doing my best to get it done as quickly as I can. So when that gets done, I'll be advertising that as well for people, hopefully as a resource that they can use.
Well, I suppose on behalf of myself and our audience as well, thank you for that work. As you say, somebody's got to do it. And when we want something done in the world, we got to go out and do it ourselves. And you most certainly seem to be kicking
Of
ass in
course,
that
yeah,
regard. So yeah, so look, we'll leave it there for today, and thank you so much again, David, for joining us. And we'll
yeah,
hopefully have you back on again.
yeah. I'd just like to say a massive thank you to you for inviting me on, and I'm sure this is going to go from strength to strength for you.
Thank you very, very much. That is the hope anyway.
Yeah.
We can but try, and we'll dig away and we'll plug away, and we'll get,
Hmm.
as I said, we get more people like yourself, great ideas to be spread, and I'm sure there's plenty of people out there that will love the value we're trying to give here. So yeah,
Yeah.
I wish you all the best. Stay safe, stay isolated, bump elbows, and all of those things. Uh,
Yeah.
yeah, and be good to yourself.
I will, fella. Thank you very much.
Mighty. Thanks, David. Bye
All
bye.
right. Take care.
So that's all for today and our chat with David McGettigan. I hope, like me, you enjoyed your time listening to him and you gained some wisdom from his thoughts on the nervous system and how we deal with pain and how we even perceive pain. If you'd like to find out more about David or find his pages, you can get his website at davidmcgettiganclinic.com. That's David McGettigan Clinic, so McGettigan clinic.com, or you can find him on social media at Pain and Movement Specialist. That's on Instagram. If you'd like to follow us, you can get us at LifeFit Studios on Instagram, or my personal page at JackoHalloran_IE. You can also find us on Patreon, where if you'd like to support us, you can find us at the LifeFit Podcast. So with that in mind, I wish you a great day. I wish you to stay safe out there and mind your fellow humans during this, what is a very unprecedented time. And hopefully you manage to make the most of it, find some opportunity within the whole thing, read a book, share some time with a loved one, and so on. All the best.